Okay, let us start. So we are going to look at renal cell carcinoma, which is a very important clinical entity as far as all postgraduates are concerned. And the detailed medical illustration here, it shows that there is a kidney with a tumor in the lower pole there. Okay, you can see the lower pole tumor and the double helix DNA is there, and also the cell architecture is there, showing that this has got lot of molecular pathways and pathological indicators and clinical presentations also. So welcome everyone. Today's postgraduate discussion on renal cell carcinoma. Today we will deconstruct the RCC not merely as a morphological entity, but it is molecular biology driven understanding of the genetic mutations and also which drive the tumor growth. We will cover this topic in three parts. The first part would be pathogenesis and molecular classification. The second part will be localized diagnostic workup and staging. And the third part will be the advanced systemic treatment for metabolic disease. Let us dive into the core of molecular pathways and critical pathological indicators about it. Let's go to the next slide. You can see here three pillars, the blue pillar and of course the red and the orange one. What are these? These will tell you deconstruct the WHO 2020 molecular reclassification. What happened? The renal cell carcinoma teaching itself underwent a drastic paradigm change in the year 2022 based on the WHO molecular reclassification of renal tumors and the shift away from purely morphological diagnosis. Earlier we used to say purely morphological classification. Now it is a molecular biology driven classification. And you have to understand VHL, HIF, VGEF molecular axis. What is VHL? What is HIF? What is VGEF? I am going to show you in the subsequent slides because these are the central drivers of renal cell carcinoma. Okay, now correlate the specific RCC, renal cell carcinoma molecular subtypes, with the hereditary syndromes and the systemic clinical presentations. This is how we go about. You can see here, there is a beautiful diagram of the kidney and the genitourinary tract. There is a connection between uterine leiomyomas and the renal cell tumor, which earlier we were not knowing. Okay, here is a vignette, patient vignette, 42-year-old female, incidental finding of a 3.5 centimeter left renal solid mass on ultrasound during a workup for menorrhagia, and she is symptomatic, severely symptomatic uterine fibroids. Leiomyomas were diagnosed. They required myomectomy in her 30s. Now she is in her 40s. That means 12 years before she underwent leiomyoma-related myomectomy. Now she presented with a left renal mass of 3.5 centimeters solid thing. So generally what do you think that leiomyoma is past, what it has got to do with the present one? No, it's not like that. What is the most pathological, most likely pathological diagnosis? What are the implications for her family as far as this presentation is concerned? Then let us look at the next slide. Then earlier renal cell carcinoma was not considered important. Now it is in the global cancer burden. It is always ranking in the first 10 cancer burdens of the world, particularly more so in the developing countries. The clinical burden of renal cell carcinoma is shifting now towards the localized high-risk discoveries. Now, what are the two types of we have? Earlier, we used to have the pathological classification, clear cell carcinoma, non-clear cell carcinoma. So, 75% of the RCCs are clear cell carcinoma. 25% of them are non-clear cell carcinoma. But that classification is not sufficient. We have to associate with molecular genetics this. There is a rising incidence. Why? There is a widespread imaging, cross-sectional imaging. What is cross-sectional imaging? Cross-sectional imaging means for some other disease, they would have come. You do an ultrasound, you do a CT abdomen, and you find out there is a renal mass. This is what is called the opportunity screening or cross-sectional screening. At that time, and today everybody is being imaged, the moment patient walks into the health checkup, we do an ultrasound. We do a CT whenever it is necessary. Means that the findings of having a renal mass are increasing. And also, we know that renal cell carcinoma has got a high metastatic potential despite early localized discovery. This paves way to a greater understanding of this particular thing. Now, this slide is very crucial. You would not have seen earlier. There is what is called the VHL protein. What is VHL? Von Hippel-Lindau. You would have heard that name, von Hippel-Lindau syndrome. That von Hippel-Lindau protein is there whenever there is normoxia, that is, there is no decrease in the oxygen tension. This VHL protein is manufactured from the genome 3P, chromosome 3P is responsible for the VHL protein. What does it do? This VHL protein binds to HIF 1 alpha and 1 beta, 1 alpha and 2 alpha. So VHL protein is a product of chromosome 3. This VHL protein role is to bind to HIF 1 alpha and 2 alpha. And this HIF 1 alpha and 2 alpha are presented via the VHL protein to ubiquitin. For what? For normal degradation of the oxygenated products. Now, suppose the chromosome 3P loss is there. VHL protein is not there. There is nobody to take care of HIF alpha and 1 alpha and 2 alpha. There will be accumulation of 1 alpha and 2 alpha in the kidney. These are oxidative products. These will give rise to, these they won't keep in the cytoplasm, they enter the nucleus now. Once they enter the nucleus, they will have VGF, PGDF and GLUT1. What are these? These are the vascular factors. VEGF is vascular endothelial growth factor. PDGF is, this is also platelet derived growth factor, and GLUT1. So in nutshell, what is the mechanism? In normoxia, that means where there is no tumor, 3P is working well, chromosome 3P, there is no loss, naturally VHL protein is there, this VHL protein acts on the HIF 1 alpha and 2 alpha, so much so these are presented to the ubiquitin and they are metabolized and no oxidative stress. Now what happens in a fellow who is genetically predisposed, his chromosome 3P is lost. Once the 3P chromosome is lost, VHL oxygen sensing pathway is cut off. VHL protein itself is not there. So the oxygen sensing pathway is affected by the VHL mutation. That results in HIF 1 alpha and 2 alpha accumulation, which are oxidative products. They won't keep quiet. They enter the nucleus. There they trigger the growth factors. What are the 3 growth factors? VGF, PDGF and GLUT1. These, what are these? They produce angiogenesis, unchecked angiogenesis and tumor replication and growth. See how beautiful is the mechanism. Now we have got this. We do not know around 5 years back. All this now has not been worked out. Now, what will happen with these things? You see. So based on the architecture, we used to classify them as clear cell and non-clear cell. Non-clear cell was again classified as papillary, chromophobe and unclassified. 75% are clear cells and 25% are papillary, chromophobe and unclassified together, non-clear cells. But that is not required now. Today we don't classify clear cell and non-clear cell. What do we do? By genetics we will classify. What are the genetic classifications? TFE3 rearranged molecularly defined RCC or TFEB rearranged RCC or FH deficient RCC, SDH deficient RCC, ELOC mutated. Now, the 5 genetic variants are, we no more use the classification, morphological classification of clear cell and versus non-clear cell, and under the non-clear cell papillary, chromophobe, unclassified, that is now retired. We don't use that classification, that is abandoned. We have given retirement to that classification. What is the new classification? Molecular genetics driven classification. TFE3, TFEB, FH, SDH in ELOs. Why should I know all these things? Treatment is different. Now we have got targeted treatment using the molecular genetics. We have a targeted treatment for each one of those things. With the result, I am forced to learn the new approach. Okay, now historically, there is what is called the papillary type 2. That is again in a non-clear cell type. It is no longer recommended and that classification is obsolete. It is retired. Now that bucket is now classified into FH deficient RCC, TFE3 RCC, SDH RCC, unclassified RCC. Emerging oncocytic tumors with mTOR alterations. There are two other categories called the oncocytic tumors with the mTOR receptor alterations. They are ESC-RCC and LOT. What is LOT? Low-grade oncocytic tumor. ESC-RCC is eosinophilic, solid and cystic RCC. SC is solid as well as cystic RCC, predominantly eosinophilic infiltration. These are going to be added to the new classification. Now you see, we have got that a Peyon's keys-like arrangement is there. If you look at the biopsy, the basal membrane is at the bottom, that all the nuclei are aligned to the top, and this is called the piano key arrangement in this sense. Usually the nuclei are supposed to be in the center, but because of this molecular problem, the nuclei are shifted to the away from the basement membrane towards the luminal side, and that one is that looks like a piano key arrangement, the nuclear arrangement, and this entity is a new entity. Clear cell, papillary, renal cell, tumor, not carcinoma. Now it is called tumor. CCPRT. CC is clear cell, P is papillary, RC is renal cell, and tumor. Why it is called tumor? It doesn't have malignant potential. It is something like a benign tumor only now. Now, it lacks the VHL mutation. The chromosome 3p is normal. There is no 3p loss. It is not malignant. Cells are clear, papillary in architecture. Nuclear are spaced like a piano key. It is indolent. No metastasis. Do not overtreat. Means what? If I recognize CCPRT, all I require is follow-up and no treatment is required. Because it is an indolent tumor, no metastasis, almost non-malignant, there is no VHL mutation, chromosome 3p is normal. Now let us go to the fumarate hydrase deficiency. I told you earlier, I was telling you that there are FH deficiency. You see here. FH deficiency. What is FH deficiency? Fumarate hydratase deficiency. You would have studied these things in biochemistry in Krebs cycle. Fumarate is hydrolyzed and we require a hydratase. If that is deficient, you see the biology. A Krebs cycle enzyme deficiency is the cause for renal cell carcinoma. It is a highly aggressive early metastasis and hereditary leiomyomatosis. This is associated with leiomyomatosis and RCC. This is what our Vignet patient. That lady had 12 years back leiomyomas. Now she developed a solid tumor. It must be a fumarate hydratase deficiency tumor. Fumarate hydratase deficiency drives an aggressive early metastasizing phenotype. And the catch is patient will have hereditary leiomyomatosis along. Now, FH deficient RCC, cutaneous leiomyomas may be there, uterine fibroids also may be there. You may have the leiomyoma-like thing. Leiomyoma is what? It is only a swelling related to the muscle and the fat tissue there. That occurs in the cutaneous region also. Cutaneous leiomyomatosis, uterine leiomyomatosis, or either one of them may be there along with the solid tumor in the kidney. So this is fumarate hydratase deficiency, which is a molecular diagnosis. It is not a morphological or histological diagnosis. It is a molecular diagnosis. Why I should know this? This is highly aggressive, early metastasis and requires vigorous screening and treatment. Now, how do I compare FH deficiency with SDH deficiency? SDH deficiency marks a rare indolent tumor-linked paraganglioma syndrome. So it is very different from the FH deficiency. FH deficiency is common, it is aggressive and metastasis. Here it is rare, SDH, very indolent and linked to associated paragangliomas. There it is linked to leiomyomas. So this is a generally indolent associated with paragangliomas, pheochromocytomas and gastrointestinal manifestations also. This is called the GIST. Okay. So the SDH deficiency is succinate dehydrogenase deficiency. FH deficiency is fumarate hydratase deficiency. Succinate dehydrogenase deficiency. This is also an enzyme in the a step in the citric acid cycle. And this while FH deficiency is highly aggressive and frequently metastasizing, SDH deficiency is generally indolent and it is linked to the hereditary paraganglioma and GISTs. What are GISTs? Gastrointestinal stromal tumors. GIST is gastrointestinal stromal tumors. So if somebody has got endoscopy, you find gastrointestinal GIST, and also you have got a renal tumor, which is a rare indolent tumor. It is probably SDH deficiency. Now what did we find already? FH we have found out, SDH we have found out. Now, and also we have found out VHL. VHL is the primary one. VHL, FH and then the SDH. VHL is that one hippolendu protein. How it affects the oxygenation pathway in the kidney we have seen. The fourth one here, VHL first, FH and SDH type, and we have got the ALK type. ALK rearranged RCC. Now, rare, affects both adults and children, mucinoid background, myxoid changes will be there, 30% show aggressive behavior, potentially targetable with the ALK inhibitors. What is the advantage? This is ALK related disease. If you have ALK inhibitors, you can target this particular disease. Now, BCL ALK gene fusion variant linked to sickle cell trait. You see, sickle cell anemia also, there is an ALK rearrangement. Because of that only the sickling occurs in the RBC. This ALK rearrangement along with the VCL gene fusion produces susceptibility to targeted ALK inhibitor therapy. That means patients with sickle cell anemia would be candidates for ALK type of RCC, and this is amenable for treatment with ALK inhibitors. Now what is the next one? Specific clinical red flags which mandate immediate genetic evaluation. When do I order a genetic test? First and foremost is age less than 46 years. That means in an young individual, if renal tumor is coming, you have to evaluate the genetic. Another thing, the second condition, multifocal. That means in one kidney more than 2-3 masses are there. Or bilateral renal masses. Both kidneys are affected. Or patient has got a family history or personal history of RCC. One family member had RCC. Or specific histology confirmed on pathology. What are they? Histologically, we have FH deficient, STH deficient, or the Britt-Hogg-Dubé type. That is the ALK. And if we find any of these things, age plus any of the three things, multifocal tumor, bilateral renal masses, personal or family history of RCC, specific molecular biology type confirmed, then you are bound to do the genetic evaluation. Now, local invasion versus systemic paraneoplastic effects. Okay, what can happen? Hypercalcemia may be there. IVC tumor thrombosis, potential inferior vena cava thrombosis and renal vein thrombosis can occur. And non-metastatic hepatic dysfunction can occur. And most important clinical finding is a man presented with a left-sided varicose vein, let us say, and he has got an RCC. There is a catch there because the left-sided varicose vein is occlusion of the left gonadal vein. If the left gonadal venous drainage is occluded, left-sided varicosities will be there. So patient presented with varicosities and renal tumor, the diagnosis is different. And there is also erythrocyte erythropoiesis is increased, EPO is more, and you will see polycythemia. These are the indications. What are the things? Hypercalcemia, IVC tumor thrombosis potential, non-metastatic hepatic dysfunction, left-sided varicocele because of the gonadal venous drainage occlusion, excessive erythropoiesis producing overproduction of the RBC. These will be the clues. Now, so our card now, what is this? Our index case, the Vignet case, 42-year-old female, we started. She had a 3.5 centimeter left-sided solid renal mass. She also had uterine fibroid. Now, the clues are, the three clues are there. Age less than 46, size is less than 3, less than 7, is important, and then uterine fibroids, leiomyoma are associated. Now, the high suspicion for FH deficient RCC. FH deficient RCC is aggressive. How do I know that? Confirm via immunohistochemistry loss of the FH protein. Now you stain the tissue for immunohistochemistry and FH protein loss. You can see this is an FH deficient renal cell carcinoma. Requires aggressive surgical management despite the small size. Size is only 3.5. But I have to aggressively treat. Why? She is young, less than 42, and it is coupled with uterine fibroids earlier. Now on doing the immunohistochemistry, I find that FH protein is deficient. This is a FH deficient type of RCC, which means it is an aggressive type. I cannot risk anything and immediately take the surgical management, probably partial nephrectomy or total nephrectomy. We have to do with 3.5 stage also. It mandates immediate genetic counseling for the patient and the family because this is genetic and her children can also have this. So, you have to have a family counseling, genetic counseling is of the order. So, in the first part, these are the board takeaways, critical synthesis for modern RCC management. What are the takeaways, take homes for the first part? WHO 2022 is a molecular diagnosis established. There is no morphological classification now that has become obsolete, retired. Papillary type 2 has been shattered and it is given into distinct entities. That is one important thing. Second thing is CCPRT, which is this is a tumor and not this is clear cell, renal tumor. This is an indolent tumor. Clear cell papillary renal cell tumor, and it lacks the VHL mutation. 3p chromosome is normal. It does not metastasize. It does not require any treatment except follow. Now, the third takeaway is fibroid plus RCC, very dangerous because FH deficient RCC, aggressively I have to manage this. Now, anatomy explains the pathology. There is a left varicocele and there is a renal tumor. Now I know what is the cause of the varicosity because of the renal venous occlusion. Anatomy, pathology, connection. These are the four important things we learn. Now we go to the second part, diagnostic workup and staging. Let us see that. So how do I do the diagnostic mapping? Navigate the indicators for multiphasic CT, MRI, renal mass biopsy. Three investigations are there. One is called the multiphasic CT. Second one is the MRI. Third one is the RMB. RMB is renal mass biopsy. These are the three indications. How do I stage? Apply AJCC 8th edition criteria, TNM criteria. I'll show you in the next slide. And integrate the 2022 WHO histological and molecular classification. Now, surgical and ablative paradigms are there. There are two options. Radical surgery is possible. Partial nephrectomy is possible. Non-surgical alternatives have come. Active surveillance and ablation procedures can be done depending on the tumor, depending on the localized disease. And not only that, I have drug treatment for renal cell carcinoma. Implement the Keynote 564 paradigm shift, which is the latest 2026 guidelines. Risk stratified EAU post-operative follow protocols. So 4 catches are there. What are the diagnostic techniques, how to stage it, and what are the paradigms of treatment, and what are the associated monoclonal antibodies as a oral drug treatment. Now you see. Interactive clinical vignette. You have now, I am giving another case now. A patient profile, 64-year-old female, and asymptomatic presentation, and it is a routine screening of the abdomen. We found out a mass, right radical nephrectomy, secondary to severe trauma 20 years back. What happened? She had a severe trauma and her kidney is removed, one kidney because of trauma. Now she is left with only one kidney. In that kidney, EGFR is 42, already stage 3B CKD, and doesn't have any symptoms. Incidentally, abdominal ultrasound found, which is done for a biliary colic, reveals a 3.2 centimeter solid vascularized mass in the left pole of the solitary kidney. How do I go ahead? She is such a tricky case. 64-year-old female, asymptomatic. She underwent nephrectomy 20 years back because of trauma related, not cancer. Now, present kidney function is already deteriorated, stage 3B. Incidentally, we found 3.2 centimeters solid vascularized mass. Now, if I remove that kidney, she will be on permanent dialysis. I can't afford to do a total nephrectomy because of this mass. So, can I medically handle it? Can I do ablative procedure, or can I do a partial nephrectomy and save the nephron attitude so that I can prevent permanent dialysis for it? So now we have to evaluate this patient. Now, so multiphasic CT versus MRI, both are available. When I do multiphasic CT, when I do MRI, the European Association of Urology and ESMO gold standard for that, with excellent spatial resolution is multiphasic CT. Strengths are excellent spatial resolution, optimal for assessing the vascular anatomy and venous thrombosis. Limitation is you cannot expose the CKD patient to an iodine contrast dye. If I have to do multiphasic CT, I have to give an iodine contrast dye. This patient is already having EGFR, which is less than 40. So I can't risk giving an iodinated contrast. In such a scenario, what do? I have to do the multiphasic MRI. Here, the problem solving modality CKD alternate. Superior characterization of small indeterminate and complex masses and assesses the enhancement without iodinated contrast. The preferred cross-sectional modality for this 64-year-old female with EGFR of 42 and to preserve the remaining nephrons. So in such a scenario, instead of ordering a multiphasic CT, I will order a multiphasic MRI. Okay. Now, renal mass biopsy. This is another investigation I told you. Renal mass biopsy, indications and safety profile. The core principle is RMB is not mandatory if the mass is unequivocally malignant. Means what? If you know from ordinary imaging that it is already a malignant tumor, there is no reason you should do biopsy. Straight away you proceed for the treatment. RMB is not mandatory if the mass is unequivocally malignant. Okay. Now, on imaging, if you find that it is unequivocally malignant and the patient is proceeding directly to extirpative surgery, then I don't require renal mass biopsy. Now, what do? Solid enhancing renal mass found on ultrasound or CT. Renal mass biopsy is an option. When do? When surgical extirpation is directly indicated by the malignant nature of the imaging, then I don't do the renal mass. If I take the renal mass biopsy, I have three procedures can be possible. One, ablation, two, active surveillance, two, systemic therapy with the drugs. With these three things in place, I am tending to do a mass biopsy, whether I can stop with ablation itself, or I do nothing and only do active surveillance and follow-up, or I use a systemic oral therapy. Absolute indications 2026 EAU guidelines prior to ablative therapies to confirm histology. Supposing you want to give ablative therapy, you require to know what is the histology. For that, you require a renal mass biopsy. Prior to entering into active surveillance, before initiating systemic therapy for metastatic disease. Safety profile, high diagnostic accuracy, very safe procedure, risk of tumor seeding is negligible, renal mass biopsy is absolutely safe procedure. What is the clinical application? Highly indicated for our patient to rule out benign entities. Why? This lady is a 62-year-old lady, already one kidney gone, we have got one renal tumor. If it is a benign tumor, I don't have to go for the surgery. I can save the kidney. I can all, if it is a locally malignant one, I can do ablation procedure. Or if it is a very indolent tumor, I can put it under active surveillance and do nothing. For that reason, I require a sort of this particular renal mass biopsy is required. Now let us see. The next slide, what did we do? Okay, there are three things I have. This is called the TNM staging, late advanced TNM staging as per the AGCC 8th edition. Okay, it's only very latest classification. The first one is the cyan colored, that is the blue colored ring. That means tumor less than 7 centimeters. That is again A and B. T1A is less than 4, T1B is 4 to 7. Less than 7, other again two types, T1A and T1B, 4 centimeters or less, 4 to 7. T2, the amber colored one, that is limited to the kidney, but the size is more than 7. 7 to 10, more than 10. That is T2A and T2B. The coral color, the third one, is the tumor extends into the major veins or perinephric tissue, but not beyond the gyratops fascia or into the ipsilateral adrenal gland. The fourth one is it did not respect the geratophasia, it extended beyond the geratophasia, or it went into the ipsilateral adrenal. These are the four stages. I am repeating. You have to remember them because the treatment depends upon the stage. T1 less than 7 centimeters. In that T1A is less than 4, T1B is 4 to 7. T2 more than 7 centimeters. T2A is 7 to 10. T2B is more than 10. T3, a tumor extends to the major local vein and perinephric tissue but did not cross the geratophasia and no adrenal gland involvement. Stage 4, it invades the geratophasia beyond and it has crossed onto the ipsilateral adrenal gland. This is the latest TNM classification of 2024 AJC 8th edition. Okay, now WHO 2022 update. Clearly, the clear cell carcinoma remains most common by VHL pathway. Clear cell carcinoma, RCC, is the VHL cancer today. Earlier, we used to call it as clear cell RCC. Today, that is VHL pathway. What is VHL pathway? 3p chromosome mutation. So much so VHL protein is not there. So much so the oxidative pathway is not taken care of. And then there is a this excess production of the oxidative thing, vascular growth factors are triggered, VGF and then the PDGF and GLUT1, they are all stimulated. Papillary RCC is no longer subdivided into type 1 and type 2. Now instead, the papillary is subclassified into various molecular entities. Molecularly defined tumors with distinct hereditary implications. SDH deficient, FH deficient, TFE3, TFEB, and ALK. These are all the various types according to WHO 20. Now you must go and do this renal scoring. What is renal scoring for nephrectomy? Assessing the surgical complexity for a partial nephrectomy. I use the renal score. What is the renal score? R is the radius of the tumor. 4 centimeters or more than 4 centimeters, like that. E is exophytic, endophytic properties. N is nearness to the collecting system. A is the anterior tumor or posterior tumor. L is the pole, location to the pole. Is it upper pole or lower pole? That is L. A is anterior or posterior. E is exophytic or endophytic property. N is the nearness to the collecting system. R is the radius. RENAL. R radius, E exophytic, endophytic, N nearness, E anterior posterior, L location, polar tissue. This renal score must be obtained. Now, you see there, radical nephrectomy versus partial nephrectomy. Should I do a radical nephrectomy or should I save the nephron and do a partial nephrectomy? Radical nephrectomy is complete removal of the kidney, including the geratophasia. Standard for T2 plus complex tumors where nephron sparing is impossible. T2 grade plus, if it is there, T2 grade plus means T3, T4 and 10 centimeters T2B. These are candidates for radical nephrectomy. Now, whereas partial nephrectomy, excision of the tumor with a margin of the healthy tissue. This is partial nephrectomy. Now, what are the factors which determine the oncological efficiency? How efficient is my surgery? 2. How much kidney I need to preserve? Renal preservation. And what is the surgical complexity? That is one factor. And finally, what is the CKD or CV risk reduction? These four are important. Of them, most important two ones, see those internal, the multilateral, multi-quadrant diagram. The greater the deviation, the more important it is that this type of diagrams you should try to understand. If you see this, the blue line is much larger than the gray line or this gray line. Means renal preservation takes an upper hand and oncological efficiency takes an upper hand. Surgical complexity and these take a lower hand. This sort of diagrams, they are new type of presentations you should understand. So now you have got the EAU, European Association of Nephrology, and also NCCN guidelines are in place. Partial nephrectomy is the absolute gold standard for T1 tumors. It provides equivalent oncological control to the radical nephrectomy. And internal medicine impact is, if you preserve the nephron by partial nephrectomy, it will protect from the cardiovascular disease. We very well know that patients of renal disease, they don't die in the renal unit. They die in the cardiac care unit. Why? Renal failure is cardiac failure. Mostly, if you save the kidney by partial nephrectomy, you save the glomeruli, you save the heart thereby. So that is the impact of partial nephrectomy. Next you see, we have got active surveillance and image-guided thermal ablation. Two new procedures have come. Earlier we have discussed partial nephrectomy and radical nephrectomy. In this slide, we are talking about active surveillance and image-guided thermal ablation, cryotherapy or RF therapy, radio frequency therapy. When do I do active surveillance? Small renal masses less than 4 centimeters. Elderly patient, they have multiple comorbidities, they cannot undergo the surgical risk. And histologically slow growth rates of 1 to 2 millimeters per year, low metastatic potential for masses less than 3 centimeters. The first question is, what is the size of the mass? If the size of the mass is around 3 or 4, if the patient is elderly, if he has got comorbidities, is a poor surgical risk, active surveillance is the answer. Second one is image-guided thermal ablation, indicated for very frail patients and those with imperative indications, solitary kidney, bilateral tumors, high-risk end-stage disease, who desire active intervention, requires prior RB to confirm the histology. If the histology shows highly malignant, then I have to go for radical nephrectomy. If the histology shows very indolent tumor, then I can be very conservative and do only thermal ablation. Offers excellent local control with minimal nephron loss. Now you say there are two variables, tumor size less than 4, more than 4. And also the patient frailty and surgical risk, low risk, high risk. High risk, tumor size less than 4, indication is primary the active surveillance and focal ablation. Suppose somebody has got low risk and then the tumor size is very low, then there is no problem. You can take up the case for, you see the size of the tumor there. You can see the size is there. And if it's a bigger size, then of course I'll be forced to take up either partial nephrectomy or total nephrectomy. Now, advanced disease, venous thrombosis, 3A and 3C means what? There is an extension into the renal vein, there is an extension into the inferior vein, or an extension into the infrahepatic and inferior vena cava. Okay, now RCC uniquely propagates via endovascular extension. See, all the tumors to propagate through the bloodstream for metastasis. Here, RCC propagates via endovascular extension, whereas most of the tumors go by the bloodstream and not endovascular extension. Multidisciplinary complexity, higher level thrombi, level 3 and level 4 require highly coordinated surgery involving urological, vascular, cardiothoracic surgery. And oncological note, despite aggressive vascular extension, if entirely resected without distant metastasis, patients still achieve a long-term cure. That's very now. So geriatric frailty and nephrology assessment are important. How bad is the patient surgical risk? Can the patient withstand the surgery? That has to be done. The CGA is what? Comprehensive geriatric assessment. Every patient, elderly patient who is going into these mutilating surgeries, there is a protocol called the comprehensive geriatric assessment. This you have to do. The European Union of Urology 2026 strongly recommends formal frailty screening to weigh the life expectancy against the risk of RCC. Suppose a patient is very frail, he is going to live for 6 months or 8 months. Why do this useless surgery and then shorten his life in the surgical discipline? You may not as well not do that. Another patient is there, 40 years young, he is, his CGA assessment is excellent. You can venture to do a little more aggressive procedure. Now, this is about the CGA. Who does it? The internal medicine people will do the CGA assessment. Nephrology consult, mandate for patients with CKD, solitary kidneys, high risk of postoperative end-stage renal disease. Nephrology must be involved. Like, patients with already existing CKD, single kidney, and high risk of end-stage postoperative disease. Now, what is the clinical parameter? Oncological control must not trigger immediate lifelong dialysis. You have done oncological control, removed all the tumor, single kidney is there, you knocked off it, patient is on dialysis from next day. What is the use? You are putting the patient to unnecessary risk lifelong. Dialysis is not one day procedure. For example, in this index case, where we are discussing solitary kidney lady, we remove the kidney because of the tumor, then she doesn't have any nephrons, and what she have to put them on dialysis. So there are the two dials are there. One dial is the CGA fragility index. How fragile is the individual? Second dial is the ESRD risk. What is the end-stage renal disease? Third thing is, am I doing the right thing in removing the kidney when it is a solitary kidney and forcing the patient to end-stage already dialysis? In that case, I have two more options now, ablation and surveillance. And depending on the type of the tumor, I can choose one of them. This is called the preoperative optimization. Now, you see that adjunct paradigm shift, the keynote 564 publication, the ESMO guidelines of 2024 and 25, historical context. For decades, no systemic therapy improved survival post-nectar. Earlier, there was no systemic treatment, only blade surgery. Now, breakthrough 564 keynote established 1 year of adjunct treatment as a standard of care. This is called the anti-PD-1. Pembrolizumab is the drug which you give for 1 year is for these patients to quieten the tumor beforehand. That means we have a medical method of treatment. Indication, patients with high risk of localized disease, post-nephrectomy, grade 4 and sarcomatoid features, and these are the node-positive patients. And finally, targets and eradicates systemic micrometastatic disease. What does this drug do? It targets the systemic microembolization and micrometastasis during the postoperative window. Significantly improves disease-free survival as well as overall survival. See the chart there. Those on pembrolizumab versus placebo. Pembrolizumab patients did very well in that study. Micrometastases are eradicated. What does it do? It is an antibody against the antigens there, and this antigen antibody complex, this is a monoclonal antibody, it reduces the risk of metastatic disease and also reduces the risk of embolization, microembolization, and the patients did very well following the pembrolizumab. So there is a medical option for those patients. Adjunct paradigm shift, keynote 564 of 2024-25. What we are talking is the latest from the literature. Post-operative surveillance protocols. What do I do after the operation? Do you leave them free? No. Core principles are surveillance intensity is strictly dictated by the final pathological risk stratification. What do I do? Low risk and low to intermediate risk. Then you have to do the 1 year, 2 years, 3 years, 4 years. High risk patients, T3 to T4, are high risk patients. So what you have to do is, for the low risk patient, prioritize ultrasound and chest X-ray to monitor recurrence while minimizing cumulative radiation exposure and contrast nephrotoxicity. Don't do too many CTs, don't do contrast studies much, and then do a chest X-ray regularly, as frequently as required, and also and monitor for the recurrence disease. When the patient is a high-risk patient, that is T3 and T4 high-grade patient, rigorously schedule multiplegic CT chest, abdomen, pelvis every 3 to 6 months for the first 2 years to detect early asymptomatic pulmonary and abdominal metastasis. There, you see so many times you are doing the CT, you can see in the picture, for the first 2-3 years, whereas you are doing only ultrasound in the case of low-risk individual and clinical examination. This is the follow-up. Now, you have got interactive case resolution, preserving the solitary kidney. Now, we have got this in this vignetic patient 64 years, 3.2 centimeters, mass is there. It is a T1A because it's less than 4. It is T1A, solitary kidney, EGFR is 22. First one is multiphagic MRI. Why not CT? Because I can't give a contrast dye because of the low EGFR. So multiphagic MRI I have done, and renal mass biopsy has been done to imperative because to confirm the disease, the type of the disease, and confirm the clear cell cancer. Partial nephrectomy or image-guided thermal ablation will be the procedure. Radical nephrectomy is ruled out for this patient because we don't want to put the patient onto the dialysis machine immediately. Nephron sparing intervention must be done. So this is the protocol. Step 1, you have got the multiphagic MRI utilized, avoiding contrast-induced thing. Second thing is renal mass biopsy to know the diagnosis, molecular diagnosis. And partial nephrectomy or image-guided ablation is the treatment. Radical nephrectomy should not be done because of fear of dialysis. Nephron sparing intervention only is practiced. Now, high yield board takeaways from the part. What are the takeaways here? Staging thresholds. T1A is less than 4. T1B is less than 7, 4 to 7. And then T3 involves major veins, strictly respects the gerontophagia. T4 is crosses the gerontophagia and goes into the adrenal there on the same side. That is this staging threshold. Nephron sparing is gold. Partial nephrectomy is the absolute standard for T1 tumors to mitigate CKD and cardiovascular mortality. Biopsy indications not required for clear-cut resectable malignancy straight away. Very clear-cut malignancies, you don't require to do a biopsy. Mandatory before active surveillance or ablation or systemic therapy. Adjunct chemotherapy, immunotherapies, adjunct to pembrolizumab, 1 year according to keynote trial is the standard for high-risk resected disease, replacing the observation only era. There is nothing like an observation only for the high-risk patients. This ends the second part. Now we are into the third part. This part is a little, I don't think we will have enough time now. Maybe we will stop here and then maybe next time we will do the metastatic renal cancer is the third part. The precision era of immunotherapy and targeted doublets. Very interesting ones. IO, TLK, all these combinations you have to understand. That we will take up in the next class. Because we started late, I would like to close a bit at the second stage without entering into the third stage. I will now you just take home messages, sir. These two slides are the takeaway things. Yeah, that slide. Yeah, where the first chapter, first part takeaway, diagnostic imaging and biopsy, staging, adjunct therapy, surveillance, and the blade, surgical and ablative paradigm. And you also have this takeaway from the second part. That is this slide is the second takeaway from the second part. T1A, T1B versus T3, biopsy indications, nephron sparing treatment, adjunct immunotherapy with the pembrolizumab. And we are now left with the metastatic renal carcinoma. That will be the next class. We will do that and take some small topic and complete that. With this, we will close here. Did you understand? Now I'll circulate some MCQs also. You see those MCQs and answer those things before seeing the answer. Once you understand the answers to them, it will go well into your mind. That will be very nice for you. Okay.